Welcome to the Velocity Made Good podcast. I'm your host, Ted Grisella. Today's guest is Dr. Veshni Pillay-Fuentes Lorente, a clinical pharmacologist at Tygerberg Hospital in Cape Town, South Africa. Welcome to the podcast, Veshni.
Thank you so much, Ted.
You were one of the scientists who was awarded a travel grant to attend the annual meeting of the American Society for Clinical Pharmacology and Therapeutics in Washington, D.C., under the Society's Low and Middle Income Country Accelerator Program. Before we talk about your experiences at the meeting, could you please tell us about your background and how you came to your current position?
Sure, definitely, Ted. Thank you for having me. So firstly, I'm a clinician. So I studied my undergraduate degree, which is Bachelor of Medicine, Bachelor of Surgery, in a very nice place in the Eastern Cape of South Africa called Walter Sisulu University. And I did 5 years of my training or my undergrad degree there. Thereafter, I went over to my place of birth, which is Durban, South Africa, and I worked there for 2 years as an intern. Thereafter, I moved across coast to the west coast, so from the east coast to the west coast of South Africa. I worked there for a good number of years, where I did a year that's kind of called community service. So that's where all doctors are required to go into more rural setting or more countryside-like setting and work for a year. And thereafter, I loved the area I was in, which was a nice small town in the Northern Cape, a very nice farm area as well. And I decided to stay on for another 4 years. And I worked as a medical officer in internal medicine. And while I was there, I kind of wanted to go back to my interest in pharmacology and was thinking of different career paths. So during that time as a medical officer, I decided to do a postgraduate diploma in medicines development and kind of get a bit of an idea of the pharmaceutical industry. And while I was doing the diploma, I got exposed to clinical pharmacology. And at that time, it was a relatively new specialty in South Africa. And the requirement to do clinical pharmacology was that you had to be a medical doctor, then with some sort of experience in either clinical trials or sitting in pharmaceutics or therapeutics, decision-making committees, and so forth. And so I decided it was the perfect space for me to be in because it brought the love of pharmacology together with my other love, which is clinical care and actually treating patients. And so I went into a 4-year training program for clinical pharmacology. And within that 4 years, I had done my master's in clinical pharmacology and then transitioned as a consultant at Tygerberg Hospital. And Tygerberg Hospital is the second largest hospital in South Africa. And during that time as a consultant, I was approached with a clinical question, and that kind of evolved into a PhD. So where I am right now is a consultant at Tygerberg Hospital, currently on sabbatical leave, completing my PhD. So in a nutshell, that's my background, and that's what brought me to clinical pharmacology.
So in looking at some of the research that you've done a number of studies where you've looked at differences in patient populations in different countries in Africa to try to reconcile the dosing recommendations that are in the product labeling. And I appreciate how difficult it can be to develop product labels for countries in Africa because, of course, the patients aren't necessarily exposed to the drug as part of the big clinical trials that are done to get regulatory approval. So I was wondering if you could talk about that challenge of trying to get to optimize doses for populations and, some of your experiences in trying to get those doses correct.
Great. So this comes down to one of the challenges we face on the African continent in terms of infrastructure. We know that much of the clinical trials have been well done in the global north, in middle to high income countries. Not much is done on the African continent. Apart from HIV, TB, because I think mostly HIV, TB, or parasitic diseases are done a lot on the African continent. But because of infrastructure and the lack of infrastructure in various countries on the African continent, we cannot conduct these clinical trials, readily in our patients. So often as clinicians, we on a typical day would see conditions where, we know that this is the guideline, we know that these are the medications we need to give. So we administer them, but we administer them with often lack of data in our population. And as these patients receive these medications, we realize as we do more research and see these patients more regularly that we don't see adequate clinical responses. Of course, this is not in all disease settings, mostly in disease settings where we see quite variable pharmacokinetics with certain drugs, and also different resistant strains, different diseases, different areas, then environments that kind of influence these strains. One of the work I was privileged to work on was data from kind of a bigger group in Europe who had done some work on trichuriasis in Tanzania as well as Ivory Coast, and they found some interesting differences in responses on the two countries. And so we wanted to go back and look at, okay, so why are we seeing a difference? Is there an issue with the dosing, or are there differences in terms of how both these populations or handle the drug in terms of pharmacokinetics? And so that was actually my first piece of modeling work, pharmacometrics, and that's a conversation for another day because it's also a scarce skill on the continent. But when I looked at this data, I had the privilege of working with our larger group, which is Pharmacometrics Africa as well, who's done a lot of work in this space. And we kind of figured out that the difference in clearance of the drug that was used to treat this infection, trichuriasis, which is predominantly albendazole, was quite different in terms of clearance between the populations. And from that model, we could simulate starting doses and consider taking it into other prospective studies. So that was one. But another area where we often see differences in terms of dosing is a part of my PhD work at the moment, which is a drug, a last line antibiotic that we use in Africa, well, actually in South Africa, and that's called colistin. This is typically used in patients that have multi-drug resistant gram-negative bacteria. And it's our last line antibiotic, meaning that, these kids and these infants, these adult critically ill patients as well, are totally resistant to all other antibiotics we have on the ground. So we've got colistin, and we need to learn how to use this better. So much of the dosing guidelines and recommendations recently have come from studies in the global north, nothing that includes African patients. And so we actually, at this point, want to evaluate whether the doses that have been recommended is adequate in our patients. And what sparked this interest is that the latest dosing guidelines have actually suggested lower loading doses compared to what we were using previously. So we're at a point now where we're comparing whether the newer dosing guidelines is giving us good enough exposures compared to the older dosing guidelines that we were using. And this is a typical situation where there's been so much of studies on this drug, but none done in African patients. And we expect that, we are quite diverse, and we would expect some differences, if not genetic differences, at least differences in terms of pathophysiology or diseases that we see more frequently that can affect the pharmacokinetics of the drug. But that's just two instances. And I think I'm really glad that clinical pharmacology is a specialty that took off in South Africa. And I believe that this is going to spread throughout the continent because it allows us as clinicians to actually be trained to do this type of research. Whereas, if you're not in this space and if you're just in surgery or obstetrics, you really think about the actual pharmacology and the differences you're seeing. Whereas if you have a dedicated specialty such as clinical pharmacology, you can actually dedicate time to do such research and understand this PK in our population better.
There has been a lot of work done on pharmacogenomics on the continent. And you mentioned Pharmacometrics Africa, and they've run a number of different training programs in a variety of different universities across the continent. And as the population of clinical pharmacologists increases, how do you What do you see as the big changes that you would anticipate happening? I realize that in some ways it's a nascent discipline right now, but as more people are trained and there's a greater awareness, how do you see the opportunities changing?
So I actually see the opportunities around conducting clinical trials, in the continent, in diseases that also affect our population, and with drugs that we're also using on our continent increasing. And for me, that's a big thing. As clinical pharmacologists, part of our training is multifaceted. And we actually have three facets. The first is patient care, which is direct patient care as well as indirect patient care, where we're involved in policy development. The second facet is clinical trials and research, whatever that methodology might be. And lastly is teaching. So as the clinical pharmacologists grow on the continent, what I believe will also happen is that people will be more familiar and will be trained in terms of how to conduct clinical trials in their spaces. Apart from that, it will also allow for greater collaborations and capacity building. So, a typical example right now, South Africa has this really nice developed clinical pharmacology program, and the registrars, I believe what you would call in the US, Ted, would be residents, so similar to us here. They actually have created a joint clinical pharmacology meeting. So on a certain day of the week, we would present a topic, but we would open this continent-wide. So we have people and clinicians interested in clinical pharmacology or pharmacologists actually joining these meetings. And what's happening there is that it becomes a larger discussion. It's not just what's happening in South Africa, but then we're kind of also sharing our experiences and we're learning from each other. So as clinical pharmacologists increase, I see collaborations on the continent actually getting bigger. I see network groups getting bigger. And I also see capacity building in terms of, can we improve our clinical trial infrastructure? Can we do more for our patients? Can we do more research? And you mentioned Pharmacometrics Africa. At this point, Pharmacometrics Africa has a great vision to actually train and upskill people in pharmacometrics. So we don't just analyze this data on a simple level, descriptive way. We can do more in-depth analysis on this. And more than that, African scientists on the continent can collect the data and then analyze their own data as well and kind of see that impact in clinical care. So that's what I foresee in the coming future.
You were awarded the travel grant I mentioned to attend the ASCPT meeting in Washington a few months ago. And I was curious to get your take on that meeting. Can you talk about some of your experiences there and, that works with, the networking that you were just telling us about in the continent?
Firstly, I'm extremely privileged to have been given that opportunity to travel. It was such an amazing experience for me. It was my first conference of that kind. And my experience from that was, firstly, I absolutely loved the way ASCPT had conducted such a conference. It wasn't the didactic way of we're going to have didactic lectures or talks and then that's it. What really stood out for me from that was actually seeing how this was presented to the audience. So, for instance, having things being presented in a way of interviews, which is more engaging than just listening to some person speaking through a bunch of notes on a slide, and that for me was more engaging. I was really impressed with the patient forums, like kind of bringing patients into what we're doing. And as scientists, understanding what these patients go through. Because most of the time we kind of sit in our box and we're so focused on we need to do ABC. But how often do we think about, the person that's receiving whatever we're doing on the other end and their take from it. So for me, this was a conference of a kind where, it didn't only have scientists in the room, it had people that were key stakeholders in the type of work that we do. In terms of the LMIC program, I've gained so much from this because apart from just the travel to the annual meeting, we were attached to mentors. And these mentors also kind of got to understand our interest. And then from our interest, also connected us with key individuals that, we could discuss and share experiences with. So when we got to the annual meeting, I had the privilege of meeting some of those individuals. And the way I thought of this was, when I go to an annual meeting, I always want to see how can I expand this network because, like I said previously, on the continent, most skills such as pharmacometrics are scarce skills. And now we're at a point where we have more training in pharmacometrics and so forth. But when I entered my PhD, I was also tasked to develop the pharmacometrics unit within our university. So being attached to a mentor who was running a pharmacometrics unit or modeling unit and who were working with clinicians, working with pediatric patients as well, which is exactly my field of interest, I could relate a lot and I could gather a lot from that. And so those are actually networks that I hope to grow back home. So, for instance, if we had to come across a funding opportunity, it'll be really nice to have these individuals on board to guide us through these type of things. And not only that, if I need to kind of get more experience on a certain topic, talking about student exchange systems and kind of sharing knowledge and seeing how we can develop the same capacity here, those are key things that I believe I gathered as starting points within the annual meeting.
What do you wish that ASCPT knew more about in terms of the particular challenges that you're faced in your research and in your teaching and in clinical practice?
In terms of the challenges we face, that there's various challenges, but I think most or the largest challenge we have is generally around funding. For instance, going to a conference of ASCPT nature, funding is usually an obstacle for us. So I was quite privileged and thankful that ASCPT had come up with something like the LMIC program. I think other challenges, which it seems like ASCPT has already caught onto it with the LMIC program, is the fact of mentorship. Because generally, you would have an individual here on the African continent who's interested in a certain field, but most of the time, there's either no experts within their setting to help them and to kind of give them a bit more guidance career-wise, or to let them know, is it a good career path to choose? How do you go about it? And things like that. And I think what ASCPT has kind of started doing with the program, and would be nice if it's done outside of it as well, is actually to have a mentorship program running where you could probably latch onto ACPT if you feel like, okay, I'm doing a grant application and this is the type of funding it is. Maybe some thoughts on how do you approach something like this, and kind of be linked to a mentor who you could talk through issues with and talk through difficulties, and would help you kind of put things into perspective of where do you need to start, and how do I progress with this. So I think, of course, the one aspect is the finance aspect, which the LMIC program, I believe, is a good initiative there. And I think that the mentorship could actually go beyond the LMIC. And currently what's happening is that the mentor we are attached to as being part of the LMIC cohort, it doesn't just end when the program ends for you. It's generally our responsibility as well to kind of continue with the mentor, which is nice. But I think something like this outside of the LMIC program would also be good. I think that's the two things that come to mind.
There are right now in the popular press a number of controversies that have been waging in the U.S. in particular And I'm sure that they'll eventually make their way to you. Things like, how do you deal with pandemics when you don't have very much information about the instigating agent and how to effectively treat it, or adverse events of commonly used drugs in pregnancy, for example. And it feels like clinical pharmacology should be at the forefront of um, talking about what's known, talking about what isn't known, and how to make decisions in the face of that uncertainty. What I've been hearing from you is a really very deliberate effort to try to bring science to some of these questions. And so it gives me some confidence for the future in terms of, how we might learn how to use drugs better and just be smarter about how we think about patients and where we're going as a discipline. So it's really wonderful to hear your enthusiasm and your optimism for the future. It's a wonderful thing. This has been a really interesting conversation. I've really enjoyed it.
Me too. I actually just want to touch on your last point where you said that clinical pharmacologists should be at the forefront. We had, and I want to share a particular experience that we had as clinical pharmacologists during the COVID-19 pandemic. Everything was up in the air. We didn't know what medications worked. And, classical case, we're faced with this issue. How do we deal with it? And what we ended up being part of on a daily basis was a morning brief. So, what a morning brief entailed was the university got together and got all key stakeholders involved. So, infectious diseases, clinical pharmacology, virology, etc. And we all had one morning slot. So, we would have to review some drug as clinical pharmacologists that has been proposed or we think would work, look at the literature very quickly, put together a critical appraisal, put together a 10-minute voice note that was actually eventually circulated nationwide to say, this drug, this is the efficacy, this is the safety data, and this is what we recommend, this is where you need to be careful, and so forth. And that worked brilliantly. So we actually experienced that firsthand. And yeah, and I think looking back now, and thank you for giving me this opportunity to reflect on it, it worked really well. And it actually gave the clinicians on the ground who were frontline workers more confidence because they were sitting there and in the morning on the way to work in their cars, they could listen to the audio, not just look at the slides, and they felt better. When approaching the day, because they weren't alone; they were backed up by every.
There are so many things that we could talk about in that space that I would love to talk about it again at some point in time. But yeah, I think that what you're describing is the best of all worlds, where expertise is being widely shared, and we can get beyond podcasts of people who experts, but who have very strong beliefs and have strong followers. So I think the future of in this situation, this difficulty of trying to deal with uncertainty, we have a lot of work to do. And what you described is an excellent first step. But Veshni, thank you for taking the time to have this conversation with me today. And I really enjoyed learning about your program more. And I look forward to seeing you at the next, at a future ASCPT meeting.
Absolutely. It's been a privilege. And thank you, Ted, for having me.